This morning, we are talking about pneumonia and tuberculosis, but we narrow down to children. And these are two of most dangerous but often misunderstood illnesses. And according to the Kenya Demographic Health Survey, that is KDHS, we are working with 2023 data. And just to note that the KDHS, Ministry of Health, WHO, usually have a 2-year time, let's say, lag as to how they release data in regards to pneumonia and tuberculosis. KDHS says that two of the leading cases of child illnesses and death, that is pneumonia and of course tuberculosis. We are working with 16% of under 5 deaths caused by pneumonia and TB. We have like 7,000 pediatric TB cases which were reported, that is in 2023 alone. We are hoping that when it comes to World Pneumonia Day, that it'll be November 12th, we'll have fresh data in regards to pneumonia. But like I said, this morning we're focusing on children. We do invite you to be part of this conversation on our socials at TV47 Kenya on Facebook and on YouTube, on X at TV47 News KE. You can tag me as well at Ann_Dida. I'll be sure to read your feedback, and shortly there will be a number on your screen. That is our call-in live phone number. Dr. is here to answer all your questions, and I'm talking about Dr. Evelyn Agisa Kegode. That is a consultant, pediatrician, and chest specialist at Gertrude's Children's Hospital. Asante sana daktari once again for making time.
Thank you. It's a pleasure to be here today.
Great. We're talking about pneumonia and tuberculosis, daktari, two of most dangerous illnesses. And like I said, it's often misunderstood, right? So if we're talking about two diseases which are critical, both at the same time, yeah? So what is the correlation between pneumonia and tuberculosis?
Well, pneumonia is usually a respiratory infection that affects the lungs. So it's due to infections like viruses, bacteria, or fungus. So tuberculosis is a bacteria. It is a slow-growing bacteria, and it causes pneumonia among other problems in the body. It affects all organs, and commonly it can also cause pulmonary tuberculosis, which presents as a type of a pneumonia. So that's usually the correlation. So children with pneumonia may actually have tuberculosis as one of the causes of their pneumonia. Yeah.
Children with pneumonia may actually have tuberculosis as one of the cases. And you know, one of the questions that most people may wonder is it possible for a child to, present with more than one diagnosis? And you're talking about if tuberculosis being a type of pneumonia, is it possible to have them all at once, both pneumonia and tuberculosis at a go?
Well, indeed, they can have actually the tuberculosis and other bacterial causes of the pneumonia in the same child. So the tuberculosis predisposes them to get other pneumonias. So bacterial pneumonias, like the streptococcus pneumonia, the Haemophilus influenza pneumonia, those are other bacterias, as well as viruses. On top of their tuberculosis, it causes a type of immune suppression in the body and predisposes them to have other pneumonias as well. So they can present in the same child, unfortunately. Yeah.
So when we talk about tuberculosis, often this is a disease that, has been made, this is a myth, yeah? We often relate it to be an older people, disease. But now how comes that a child now start to present with, TB, and I understand that this could be an airborne disease as well. Yeah. How does it now come to the point where, this child is presenting with tuberculosis and being airborne, yeah? This is not something that we would say that is transmitted. And you correct me if I'm wrong, yeah? We see cases where they say that sometimes a mother may have tuberculosis and then it goes down to the child.
Correct.
Just try and educate us on that.
Well, yeah. So tuberculosis affects all age groups. From a newborn in utero, because there is congenitally acquired tuberculosis, where the organisms cross the placenta and infect an unborn child. So a newborn can present with features of tuberculosis if the mother had tuberculosis. Also, if the mother has tuberculosis and delivers a baby, and it was undiagnosed, and the child can actually still have tuberculosis through breastfeeding. The bags can cross from breast milk to an unborn, to a newborn baby, and younger children in the house can also get tuberculosis from the older people in the house who have tuberculosis, because it's a respiratory disease spread through droplets. When we cough, we sneeze, shouting, singing loudly, they spread the organisms in the air, and the organism can be suspended for a period of time, especially if there's no good ventilation, the flow is not good, they can stay there for a bit of time, also in dark areas. So those are things that increase the risk of transmission of tuberculosis in the household members. Younger children tend to get from adults, unfortunately, especially if the cough that is coming out has the tuberculous bacteria. So all age groups from newborns, adolescents, in schools, old people are at risk of getting tuberculosis. Yeah.
If we talk about pneumonia, Daktari, I understand that there are different types of pneumonias. And how differently do they present themselves in children? And even as we look at these children and how pneumonia presents itself, then let's go to in adults as well, yeah? How do they now react differently? You know, we'd say that a child would maybe cough if they have pneumonia, maybe TB, but how do they differ between adults and children?
Well, so children's lungs are still small, their airways are quite small, so the respiratory presentations in young children might be quite dramatic. So they present with fast breathing, difficulty in breathing. The chest wall is very compliant, so it goes in and out, especially if the disease is quite severe. So we usually are able to diagnose pneumonia because children are breathing very fast. The respiratory rate goes higher to try and compensate and deliver oxygen in the body. Also, the work of breathing starts going high because the body is really trying to bring in oxygen. So the way they're breathing, they're using extra muscles that are not usually responsible for breathing. They're now coming in. So we see the nose starts moving in and out. The lower chest wall is also going in and out, in and out. And the more that happens, the more severe the disease is. So the airways are quite compliant. That is different from adults who have a rigid chest. So we don't see that in adults with pneumonia, but they can present with cough, chest pains, and complain of also of difficulty in breathing. So that's usually one of the different ways of presentations. The presentations differ among the ages. The respiratory rate also, in younger babies, it's faster compared to bigger children. So the faster it is, we see the body is really working hard. And other symptoms of severe disease are usually there in children as well, like refusal to feed. There's usually also a fever. There's usually also sometimes vomiting. Very sick children don't want to eat. It's a sign of severe disease in children. So it can be there in severe pneumonia. So when we see that, we recommend they come to the hospital immediately. We see if they need any extra support, oxygen, and start on antibiotics if the pneumonia is due to a bacteria. So for TB also presents the same way. However, the symptoms are there a bit longer. So coughs that are persisting beyond 2 weeks, the child is not adding weight well, is losing weight. We have drenching night sweats. The child is sweating a lot. And also fevers that are not going. They're not responding to the usual medicines that we give. So when we see that, we suspect now we may be having tuberculosis, and we need to look for it. Sometimes we don't find it. If we suspect it's there from an adult who had TB, then there's a high likelihood we may be dealing with tuberculosis, and we might actually recommend treatment for that. So
is there a challenge with diagnosis when you're talking about pneumonia and TB? Because you say that sometimes it's hard to identify which disease or illness the child has. Then is that a challenge when it comes to diagnosis? And how does that now affect the quality of care and how you present or recommend medication for these children?
Indeed. There's a big challenge in diagnosing tuberculosis, especially in children, simply because our younger children are not able to cough up the sputum that we need to diagnose it. So, and the yield from the samples we get is usually quite low, up to 60%. We are able to diagnose it, even though it's there in the body. So we encourage good quality sputum. Sometimes children below 6 years are not able to get that. So we are able to maybe suction with a physiotherapy. We induce the sputum and get aspirates. Also, when they cough, they tend to swallow the makohozi, the sputum, into their stomachs. So early in the morning, we try and get the samples from the stomach. We call that gastric aspirate, because sometimes the bacteria are still there before they eat anything. So early morning, before they eat, after sleeping, we get that sample, and we are able to get the TB there. Still, the yield is not very high. So the more samples we get, the more they help us to improve the yield. So ideally, we should try and get 3 samples. A spot one when they arrive, an early morning one, and another one. That each extra sample helps us to get tuberculosis. And younger children, as I said, it's very difficult for them to cough. Even the bigger children, sometimes we get a sample, we tell them cough deeply so that they get the nice one, not just saliva, to help us diagnose it. And it's a slow-growing bacteria, so the laboratory sometimes takes a long time to culture it also. And the stainings also are unique. Sometimes are not readily available in some centers, but there's newer methods of getting faster cultures that are available in some centers as well.
And if you talk about sputum, I understand that this could be quite a hard procedure and a tough one on the child. You're talking about somebody, a very, very young child, maybe 1 year, 2 years. So what else, the other diagnosis tools that you use apart from sputum, which is quite very, intensive on the child?
Sure. So the tuberculosis, the bacteria has proteins on the wall, and inside we call them antigens. So one of the one that we have utilized at the moment is called the urinary lipoarabinomannan, urinary LAM. We use it to sometimes screen, especially in children who have HIV or immunosuppression. If it's positive, then there's a high likelihood that there would be tuberculosis. If it's negative, it doesn't exclude tuberculosis. So that one can be utilized. Another antigen, we call it IGRA, interferon gamma assays. That's a blood test. It can also be used to screen if there's been exposure to tuberculosis. It's similar to the MAN2, like the BCG scar, the one we inject on the skin, and there's a swelling. It shows if someone has already been exposed to tuberculosis. Usually there's a reaction to that. So there's a blood version of that can be used to screen. So if symptoms are there, symptoms of tuberculosis, and those antigens are coming positive, then there's a high likelihood we could also be dealing with TB. So many people have been exposed to tuberculosis in our country, so those tests can sometimes be positive, but the person doesn't have tuberculosis.
How is that possible? If somebody, TB is high, presenting with signs of TB, but he or she doesn't have TB, how is that possible exactly?
So when we've been exposed to the tuberculosis, the body tends to mount an immune response to that. So, and it can contain it. So
a carrier.
So we call it latent TB. So it's just sitting there in the body, not doing any problem, but it's there in the body. The body has managed to contain it. So the antibody test when we run can be positive, meaning the person was already exposed to tuberculosis. So however, the challenge is sometimes the immune response goes down, and that bacteria that was just sitting there now erupts and causes the disease. So sometimes we watch cautiously the children who are having positive antibodies or positive MAN2s without having symptoms, because at some point, if they develop the disease, then we have to treat them.
So in that case, still on that point, which is quite interesting, if somebody now has tuberculosis just staying inside the body, does that open avenues for for them to present with other serious illnesses in the future? Of course, aside from pneumonia, but any other diseases that might come due to somebody just being a carrier of tuberculosis?
Okay, so the latent TB. Yeah, if it's it takes an advantage when the immune system goes down. Probably maybe the person has been put on medicines that suppress the immune system, maybe developed a cancer or diabetes or something, and then the immune system is low. If the TB was just sitting there, contained by the body, then it can actually erupt and become a disease and present with TB disease, which we have now to treat aggressively. So in some situations, we recommend that TB to be treated because it can actually progress. Yeah, but if the immune system is good, then we don't routinely, children who've been exposed to TB don't treat. Yeah, because if you're traveling and routinely we do the Mantu test to some countries or the IGRA and it comes positive and you're not sick, then it doesn't qualify you to be treated. Yeah.
Let me take you back to that point where you mentioned about, sometimes mothers may have tuberculosis and also pneumonia, and it's having the possibility of just transferring to the child as well. With HIV, we have checkups for, breastfeeding mothers and also pregnant mothers where there are just regulations put up for them and medications as well. Do we have that for tuberculosis and pneumonia just to try and, prevent this child from contacting tuberculosis from the mother?
Yes, indeed. There's prophylaxis recommended for children, especially HIV infected children. And the CD4 counts, they are actually at risk of TB disease, so they are usually put on isoniazid prophylaxis. Also, children who are under 5 and any adult in the family has tuberculosis, we recommend for the younger children to be put on prophylaxis to prevent them from getting TB. So there's prophylaxis available to protect the younger children from developing the TB. We usually screen first to make sure they don't have TB before we put on the prophylaxis. Because if they already have the TB, then we just put on the full medications for tuberculosis. If they don't, then we put them on prophylaxis, especially if they are still in the same environment. And we don't want to separate their members from each other. The families usually must stay together, the mothers, and taking care of the children. So we put the children on prophylaxis to prevent them from developing the tuberculosis disease. Also, children with HIV, most of them would be on prophylaxis until their immune system is really, really strong. Yeah.
So with prophylaxis, for how long does that take when you put these children, under, is it PrEP or prophylaxis? Is it PrEP?
Yeah.
PrEP for TB?
So okay, it's not really PrEP. So PrEP is pre-exposure prophylaxis.
Yes.
We do that. Yeah, it's kind of the same. But this one, they've already been exposed to it. But we don't want them to get the disease. So there's different regimes, but the most common one, we do the isoniazid for 6 months also. Okay. Yeah. But there's shorter regimes that are now available, even for healthcare workers who are exposed to tuberculosis. They handle specimens, they handle patients with TB, so some of them are also on prophylaxis routinely with different regimes available now.
Dr. Let's go back to the data that we are looking at, and we see that the country, we report 300 cases of pneumonia annually, and TB, we have like 10 to 12% of the total TB burden in the country. That is in regards to, according to NTP, that is the National Tuberculosis Program. This report is 2023 data. How is the situation on ground? Now that you work with, you operate on these children, you see them, you see these parents come in, they go out. What is the situation on ground? Are we seeing a rise in these cases as of 2025?
Yeah, indeed. There seems to be a rise in the pneumonia cases as well as TB cases. The recent data is showing there's actually an increase in TB, and we are actually very vibrant on the ground, trying to see the children present with features of tuberculosis, screening for them and starting treatments early, and also giving prophylaxis to the people at risk, because the cases seem to be rising, unfortunately. I know there's the Stop TB strategy that we were supposed to at least stop TB by 2030. However, it's already 2025 and we are not on track.
How are we doing? I was coming to that question. How are we doing? If you're looking at a time frame of, end TB by 2030, then how are we doing? Are we getting there? What are the gaps?
I think we are off track at the moment, yeah, because of increase in air pollution, indoor air pollution, and maybe the viruses that are actually circulating also predisposing children to pneumonias. And TB is one of the presentations of pneumonia. So unfortunately, we seem to be having more cases now, and I hope we'll be able to contain that. Yeah.
So where are the gaps exactly? Is it in terms of diagnosis, funding, how, you as healthcare providers now tend to, cases of tuberculosis and pneumonia in children? Where is that gap exactly?
So there would be a gap either in early identification of the cases. Unfortunately, with the USAID that used to really support programs, there's been withdrawal. I don't know how that is affecting
let me
now.
Just hold on there a little bit and let's get this call before she runs away. Angie, good morning. Angie's calling from, is it Machakos? Good morning, Angie.
Good morning.
Yes, talk to us.
Okay, nilikuwa nataka kuuliza.
Yes.
Swali langu walihusu pneumonia na tuberculosis, lakini hiyo nimesikia ni daktari wa watoto. Swali langu ni niko na msichana wangu uko 7 years old.
Okay.
And recently amekuwa akicomplain of pain on her left ear. And nikiangalia closely naona some sticky brownish thing coming outside from inside. From inside.
What is coming outside, Angie? Come again.
Nikiangalia closely to that ear,
yes,
naona some sticky vitu zinakaa sukari ngutu, tunaelewa. The brown sticky zinatoka inside.
Okay.
So ndo nilikuwa hata nijue daktari ananiambia kama anaweza kuwa na shida zile, ana complain iko na uchungu, alafu inatoa hizo vitu hizo sticky yani the brown. Yeah, inatoka ndani.
Sawa, asante sana Angie. Daktari, brown discharge from the child, a 7-year-old.
A 7-year-old. Well, so that's quite interesting. So if it's one ear that is actually discharging, there could be many things going on in that ear. So one of them is usually there could have been an infection affecting that ear, the eardrum, and it could have been put at risk, either very weak and there's discharge coming out, or pus. Another thing, that could be a foreign body. You know, the children, things crawl into the ears, including small ants and insects. So, or the child put something in that ear and now it's getting infected. So I would recommend, if she's able to go to the nearest hospital where a doctor can actually look with an otoscope and see what exactly is going on in that ear. There could also be just wax that is impacted. And now sometimes the wax looks black and sometimes there's the brown one. So it would be a good idea. And if she's feeling pain, it could be any of those, either an infection, a foreign body, or just wax impaction. And the treatment for each of that is quite different. So in the meantime, she can give some painkiller to relieve pain if the pain is a lot, like paracetamol or brufen if she doesn't have acidity issues, and just walk to the nearest place to ask any clinician there to just look in the ears to see what is going on in that ear and recommend the correct treatment. If it's wax that is impacted, there's drops that can loosen it and it will actually come out. If it's an infection, she would be given an antibiotic for at least a few days to clear it. And if it's something the child puts, we see that a lot. They put things, pencils, or some insects crawled inside.
Oh, wow.
Then they can be removed.
An insect?
Yeah, cockroaches, small bugs. Yeah, if they were lying down on the grass. Yeah.
And then it just goes in.
It just goes in, and maybe she pressed it and it got stuck there and it's dead. So it's okay. She can go and get it checked out, and it can easily be removed. Yeah.
All right. Asante sana Angie for that call. And if you feel like Daktari has not given you a satisfactory answer, we do invite you again, of course, to call in. But Daktari, before Angie, of course, called in, we were talking about the gaps that are existing. And you started by talking about challenges in early detection of tuberculosis and pneumonia. So what are the gaps in broader length, aside from, of course, early detection?
So the other gaps is usually late presentation to the facilities to actually a center where we can actually investigate for TB. But our guidelines are there to help clinicians to recognize features of TB and screen and maybe do a chest X-ray if recommended, and the TB tests and such treatment. So if there's late presentations, then sometimes the disease can actually advance, and that can be a gap in detecting and starting treatment. And also availability of resources to investigate for tuberculosis. That is also a gap that we could address.
And if you're talking about availability of resources in addressing tuberculosis being a challenge, how is that playing out in these rural areas? When you were starting, you talked about sometimes ventilation could be a trigger, of course, to causes of tuberculosis and pneumonia.
Yeah.
But if you're looking at some of these urban areas and rural areas, we have a lot of homes where they use the charcoal firewood to make these foods. That how prevalent, I know I'm asking you two questions in one. We are going to break them down into two, you know. We have urban areas and we have rural areas.
Yes.
How prevalent are tuberculosis and pneumonia in these two areas, urban areas and the rural areas? And now we narrow down to the availability of these resources both in rural areas and urban areas as well.
Okay. So in areas where there's a lot of house crowding and poor ventilation, even including schools, boarding schools, there can be increased risks of TB transmission in those areas. We might find TB in one household. Several members actually have the tuberculosis because there are very many people staying in a small house with poor ventilation and increasing the risks for pneumonias. Usually they cook in the same house, all of them surrounding one fire, because especially now when it's cold, and some are really coughing and the others are inhaling the bacteria. So that can increase the transmissions of tuberculosis. So in areas where there's resource limitation, poor housing qualities, overcrowding, there seems to be higher TBs in those areas. Whether it's in rural areas or urban areas where there's a lot of overcrowding, then TB would be higher in those areas. So we encourage ventilation. When they wake up, at least open the windows so that air comes in, go outside for some sunshine. The sun kills those germs, and distancing from people who cough from each other, if possible. When they cough, they vomit, those droplets can stay there, and the children can actually get the TB from the fomites if the bacteria are still there, interestingly.
Interesting. You know, now you're talking about there being a challenge in terms of just resources in these sana rural areas where, say, level 4 are not available. Tuberculosis is free, treatment is free.
Correct.
But are we seeing that also being the case for pneumonia, where treatment is also subsidized for people to also just, for these children to get treatment, if at all, it gets to a point where pneumonia is now severe and not easily treatable at that point in time?
Yeah, you're right. The tuberculosis medication is free. There's a lot of programs that are supporting the TB programs to manage children and adults with tuberculosis. Pneumonia, mild pneumonia is easily treatable, and we just give the antibiotics and they go home and they come for follow-up and we see if they improved or not. However, severe pneumonia is a burden on healthcare. It's costly. Children usually need oxygen, they need intravenous antibiotics sometimes, and it's worse if it complicates. When the pneumonia complicates, now they need to go to a higher center where they need more specialists, advanced therapies. Sometimes there's pus in the lungs. So that one needs prolonged antibiotic use, prolonged IV medications. Sometimes there's surgeries that are needed, and that can be very expensive. So that is not easily available at the level 1, level 2 facilities. It's usually tertiary level facilities that are able to manage complicated pneumonias. But simple pneumonia, and non-complicated pneumonia can be managed at lower level facilities with oral antibiotics and even the IV antibiotics that are easily available in our essential guidelines. Yeah.
All right. Let's get some feedback now from our socials. We start off with, do we have them? All right. This is Mary Wambui. She's texting us from Githurai. Anasema, my 4-year-old has had a cough for over 3 weeks. We've used syrups, but no improvement. Could this be TB?
Okay, so a cough for over 4 weeks?
4 weeks, yes.
So if there's other features in the child, like persistent fever, the child is losing weight or not gaining weight at all, and suggestive, like night sweats, usually we suspect tuberculosis if the other features are there. If there's none of those, then it could just be these post-viral coughs that are common in children, including 4-year-olds, that will go away. So if there's nothing else in the child is eating and feeding well, playing, and just the cough only, then we give it some time. But if the cough is accompanied by chest pains or problems with breathing, and the cough is always there early in the morning, at night, or when exposed to something, then it could be allergic coughs as well. So that 4-week cough could be allergies or just post-viral coughs or just a bronchitis. So Mary should just monitor, and if she's worried about any of the things I've said, then she can come to us so that we offer more help and examine.
All right, and of course we'll be referring Dr. to you at the end of this conversation. We have another interesting question here from Kisumu. This is James Otieno. Anasema, what's the difference between pneumonia and TB symptoms in small children, and how do I know which one my son has?
Okay, that's a very good question. So pneumonia and TB can present as a pneumonia, unfortunately, in small children. So that could be the first time they're coming to the hospital with cough, fast breathing, fevers, difficulty in breathing. And then when we do an X-ray, it shows the features of a pneumonia. And then there's patterns that we see on the X-ray that are suggestive of tuberculosis. And also, if we suspect, then we look for the tuberculosis. And we had said it's difficult to find it. So for young children, we really have to look. And we have several things that we put together to tell us this could be tuberculosis. So if that pneumonia, if there's other things supporting tuberculosis, then we treat it. So basically it's a clinical diagnosis, and sometimes we support it with evidence of bacteriological evidence or antibodies or antigens for tuberculosis being present. So I would recommend also just watchfully examining children, doing investigations that are relevant in children we suspect to have tuberculosis. A lot of clinicians would recommend looking for tuberculosis if the features are there. Or if the child is at risk, maybe has HIV or immunosuppression, then there's a high likelihood they could actually get tuberculosis as well, even though it can affect everyone. So those are some of the predisposing factors, like HIV, being a trigger to tuberculosis. It can predispose the child to get more easily tuberculosis. All right, let's sample a few more. We have Millicent Anasema, she's watching from Nyeri County. Are there vaccines for TB and pneumonia, and what age should the children receive them? Great. So for pneumonia, there is vaccines that are available that prevent some of the usual causes for pneumonia. They are available. We have a pneumonia vaccine. We give it at 6 weeks, at 10 weeks, and at 14 weeks. We also have the influenza vaccine, the bacteria one, the Haemophilus influenza. It protects against pneumonia, one of the most common causes of pneumonia. It covers that. And also measles, which we give at 9 months, protects against pneumonia as well. So those vaccines, all of them protect against pneumonia. For tuberculosis, the vaccine we give at birth, called BCG, that we look at the scar on the hand, protects against severe forms of tuberculosis. So that's the only one that's available at the moment to protect against tuberculosis. Unfortunately, it only protects against the severe forms, which means even after getting the BCG, we still have to take measures to prevent us from getting TB. So children who even received BCG can still get tuberculosis. So we still have to be vigilant and take measures that are helpful also.
So in simple terms, let's get this call. Diana, good morning. Diana is calling us from Kisii County.
Okay.
Good morning, Diana.
Morning.
Yes, talk to us.
Nilikuwa na mtoto.
Yes.
Hiyo mkubwa alikuwa 4 years na pia alikaa mgonjwa. Wakasema alikuwa na severe pneumonia. Hello?
Yes, hello, we can hear you, Diana.
Ni Diana kutoka Kisii.
Yes, Diana.
Kuna mtoto wangu alikuwa na walimwangalia wakapata wakasema kuna severe pneumonia.
Diana?
Wakaanza kumpea antibiotics.
Okay.
Hello?
Yes, wakampea antibiotics.
Walivompea antibiotics, mtoto hakuwa na change. Mtoto wakaendelea kumpea, tukamchange hospitali, tukampeleka hospitali nyingine pia hana change. Tena tukampeleka hospitali nyingine tena hana change. Bado wanaendelea kumpa hizo dawa, wanasema ako na severe pneumonia. Mwisho mtoto waliniacha.
Alright.
Sasa walivoniacha mtoto wakati alikufa, wakasema wacha wampige x-ray ya chest. Waangalie ni nini, kwa sababu walikuwa wanampa hizo dawa lakini hakuwa na change. Walivompiga x-ray wakapata lung moja ika affected, ilikuwa white. Sasa ni 2 weeks tangu tumzike. Niko na mtoto mdogo mwenye ako na 7 months size. Alianza kukaa na hizo symptoms za huyo mkubwa venye alikuwa nazo tena. Nikamkimisha hospitali, wakampima, tulitoa kikozi tukapima sisi wote, lakini mtoto alivyopima yeye pia kikozi akapatikana pia kwa sawa huyu mdogo. Wakampiga tena x-ray mtoto mdogo sasa hivi. Wakasema wacha waanze kumpatia dawa za TB. Sasa nimeanza kumpatia sasa hivi ni 2 weeks tangu aanze hizo dawa. Sasa mimi nilikuwa nataka nijue ni nini ilisumbua mtoto mkubwa, kwa sababu pia huyu mdogo anaanza hizo symptoms. Ugonjwa haikuwa inaonekana. Sasa hivi huyu mdogo ndo naendelea kumpatia tu dawa hivyo tu. Sasa nataka uulize daktari ni nini.
Alright.
Sijui. Huyo mkubwa alianza kukaa week. Nilikuwa namuuliza mama unasikia vipi vibaya, na ananiambia ni miguu. Mguu, alafu alikuwa weak. Alafu alikuwa anasikia kukohoa lakini anashindwa kutoa kikohozi.
Alright. Sawa, asante sana Diana for that question, Daktari. Clearly she has a lot of concerns. Constant referrals, none is working for them. Now the eldest child also being succumbed, and one also being diagnosed with severe pneumonia.
Okay.
Then what happens?
So first of all, pole sana Diana for losing your child. It's very painful. And from what I heard, the child actually had a pneumonia that was complicating. And unfortunately, she says after they did the x-ray, postmortem, the one lung was white. So that means that lung was quite affected with the pneumonia. And there's a possibility it could have been tuberculosis. That's how it presents also, with pneumonia that is not responding to usual antibiotics. So for this second child, it's a good thing someone has started on anti-tuberculosis, and I'm hoping that the child is actually really improving on the medicines, and it would be good for the adults in that house also to be screened for TB in case there is actually undiagnosed tuberculosis, because young children get the TB from adults. So I believe she will respond well if that is tuberculosis. And I would recommend if she can also just consult us and we walk the journey together in case there's anything else predisposing this younger child to get those symptoms, including any underlying medical conditions, so that we also support them. Yeah.
All right, now let's talk about treatment. We're coming to the tail end of this conversation. What are the treatment options available for both pneumonia and tuberculosis in children? How long does treatment take, and how does it look like for a child?
Okay, so for non-severe pneumonia, meaning the child has cough, fever, chest pains, fast breathing, and is able to eat, is going about their business, we usually just give oral antibiotics, and it can take 5 days to 7 days. If it's severe, we do up to 10 to 14 days of high-dose amoxicillin. Unless the child is allergic to that, then we switch to different medications. For severe disease, where the child is not feeding, is breathing very fast, is using a lot of effort to breathe, we recommend the child to be in the hospital so that we give the oxygen therapy and intravenous antibiotics until the child is able to feed and the breathing is good. Then we discharge on oral antibiotics. So in total, that can take about 10 to 14 days of treatment. If there is complications of pneumonia, that now shifts. It takes a longer time to clear that, and therapy is directed to clear why is it complicating. So that can take even 4 weeks to clear severe complicated pneumonia. It can take a longer time. For TB now is a different treatment regime. The tuberculosis bacteria is very slow growing. It is resistant to many of the usual antibiotics. It hides in the cells. So the treatment needs at least 4 drugs to start the intensive phase. We have 2 phases, intensive phase and the continuation phase. And this is just for tuberculosis that is sensitive to those medicines. So we have core drugs that we usually give, 4 drugs for 2 months. And then after that, we continue with 2 drugs for another 4 months. So that is 6 months in total, the usual treatments. If it's severe tuberculosis affecting other organs like the brain, the bones, that one now we prolong therapy as well for almost up to 9 months to a year. If it's a resistant one, it's now a different problem. That one is managed as specialists because we call that MDR tuberculosis. It's resistant to the usual medicines. That one, the medicines are unique. They have to be tailored to the culture, the sensitivity results that are out. There are several other medicines we choose from, and we give them for a longer period also. So usually we used to give for 24 months up to when the symptoms are better, and then up to 48 months. So you see, that's a year to 2 years. But the good thing is there's shorter versions that are now available that have tried to shorten the regime. So for that one, we treat it as specialized centers with specialists who have the capability to manage that. So if we are in an area where tuberculosis is very high, the child is always getting treated for TB, that one qualifies to be investigated in case there is the resistance bacteria that is there. But the medicines are available. Majority of children are cured after treatment with tuberculosis, especially if we pick it early before it causes damage to the lungs. Yeah.
And I love that you've also brought in that point, because we don't want it to look like it's a death sentence. We talk about tuberculosis and pneumonia, it affecting the bones and the legs and whatnot. But what would you tell a parent who, of course, is skeptical, about TB and also just going to the hospital? Anaona mtoto anakohoa lakini anasema hii ni kidogo sana. What would you tell such parents who are reluctant on, just going for medical help?
Yeah, so they should not be reluctant. They should not be stigmatized for if they have tuberculosis. It is a treatable disease, TB inatiba, and majority of the time we treat it, and it actually clears from the system. So when we get it early, we clear it. It is treatable. So they should not be reluctant and wait for the disease to really progress. They should come early if they suspect there is tuberculosis. If an adult had TB and the children are coughing and suffering, they should bring them so that we start them on treatment early enough, and the disease is treatable. Yeah.
All right. And of course, I promise that the far end will give you a chance to just refer. We'll give viewers a chance to contact you. Maybe you can now give us where we can find you and your contacts as well, Dr.
All right, thank you. So I'm usually here in Nairobi. I have a clinic at the Gertrude Children's Hospital in Nairobi, and also I help other hospitals around Nairobi. So I'm reachable if there's any concerns or any chronic lung problems. I'm a pediatrician, so I would support any childhood respiratory problems that are of concern, and we are available even on phone. You can send the x-rays that are looking suspicious so that we just advise on the next step. Yeah.
Another one thing on phone. Which phone? As we wind up, and I'm eating into my director's time.
So there's a phone that you can share on WhatsApp, the x-rays or the results for support, 0721 296 302, and any of the concerns about respiratory problems, and you can also come to our centers for support.
All right. Thank you so much, Dr. for making time for us to have this conversation. That is Dr. Evelyn Agisa Kegode, consultant pediatrician and chest specialist at Gertrude's Children's Hospital, speaking with us about pneumonia and tuberculosis on children. It can be prevented at very early stages, that is pneumonia, and like she said, TB in a TIBA. Do not be scared. That brings us to the end of this segment. You're watching Morning Cafe. My name is Anne Odida. Good morning.